Okay, very good morning to everybody, to all participants to the this first ELSA online conference 2020. Actually, as the Secretary General of ELSA, I need to thank all the faculty, all the sponsors for the opportunity and the trust to organize such a big task that brings us more than 140 faculty from all over the world. And today I'm inaugurating and opening this ELSA Master of Surgery lecture. And I have the privilege and the honor to introduce to all of you Professor George Hanna. Professor George Hanna is very well known worldwide, but just a short and brief introduction to him. He's actually the head of surgery and cancer at the Imperial College in London. And he's also consultant in upper GI surgery at the Imperial College NHS Trust. He trained in Ninewells Hospital in Dundee with Professor Cuscieri, and he obtained his PhD in '97 in Dundee, and then he's a FRCS in general surgery in 2003. He joined the Imperial College as clinical senior lecturer and upper GI surgeon in 2003 until achieved his top, become the head of surgery. His interest is mostly in diagnostic in cancer and GI disease. That's why the title of his lecture is an overview and a big insight on gastrointestinal cancer from minimal invasive surgery to non-invasive breath testing. Let's give a big applause to Professor George Hanna. George, you can go ahead.
Thank you. You see my screen, do you?
Yes, it's beautiful.
Right. Many thanks for the opportunity to share some thoughts with you. I have many colleagues in Asia and Japan and Korea and Singapore and other countries, and always a pleasure to be among you, even virtually. I would like to share with you some thoughts about the revolution was coming from minimally invasive surgery and where we're going forward. So ELSA, like other society, leading medical innovations. Laparoscopy has been a paradigm shift in surgery, with minimally invasive surgery has been almost the norm among different disciplines of surgery. And revolution continues with robotics, with image-guided surgery, as with also interventional endoscopy, the ESD and the full thickness resections. All those are iterations of the innovation of surgery. But we all know that in cancer surgery, the earlier the diagnosis, the better the outcome. So one of the drivers of the research in diagnostics is to have patient with earlier diagnosis, because as much earlier diagnosis we get, the more minimally invasive we can be. And over the last couple of years, for instance, the number of gastric resection in Korea done through the endoscopy is even more than laparoscopic surgery. So the question really now is how to move diagnostics beyond endoscopy. So there is a diagnostic dilemma we have in gastrointestinal surgery. There is a high incidence of non-specific symptoms. Early cancer present with symptoms which are common with benign disease. The dyspepsia, the reflux, maybe weight loss, fatigue, anemia, all those shared by many other conditions and a majority of benign diseases. At the same time, the incidence of cancer is low. The standard diagnosis for gastrointestinal cancer is endoscopy, because we need tissue for diagnosis. And this is invasive, expensive, and not present in the general practice. And it's a clinical burden for the system to refer everybody with upper gastrointestinal symptoms to have endoscopy. So what is the alternative? So if we have a triage test, which is a non-invasive test, to stratify patients to those who have endoscopy, this will make a difference because it can be in routine practice, it is easy to do, it is acceptable, and all the research to make it high sensitive too. So when the patient presents with non-specific symptoms, like we do a blood test, we can do a breath test. So Linus Pauling, he is a double Nobel Prize winner. And in 1971, he managed to concentrate breath in a cold trap and analyze it by gas chromatography. And he found more than 100 compounds in breath. So what is the volatile compound? Volatile compound is a carbon-containing compound which is sufficiently volatile to be detected in the gas phase at room temperature. And volatile compound used in day-to-day practice. We all know the alcohol analyzer for drivers. It is widely used in search and rescue by dogs. That's what they do. They pick up volatile compound. Dolphins in the ocean, when they need to know how the contamination of the oceans, they use the volatile of the dolphin for that. Even the type of coffee, you can differentiate between them by volatile compound analysis. Just what is the breath test? So breath test is you breathe in a bag, and this take less than a minute, and then use a pump with a controlled rate to transfer it into a thermal desorption tube. And those tubes could be transferred to the lab, and it can be stable in room temperature up to 2 days and even more than that, and up to 3 months if you put it in ice, and goes to the lab to analyze using mass spectrometry. And running the test takes about 12 minutes, and it's an automated system. So we can run about 90 tests in a row. So this is a breath test. From a patient perspective, is really, it takes less than a minute and totally non-invasive. So show you what to some of the results which we have done. So the first thing we have done a study in esophageal and gastric cancer and look at the compounds in the breath. And we came up with a panel which from fatty acids, aldehydes, and phenols, which we found is different between normal, benign disease and with cancer. And when we combine those panels using a heat map, we find a group of compounds which will give us a diagnostic accuracy in the model about 0.92, and when you did a validation set is about 87. So the question really now, can we reproduce the results again? And before that, we thought if we reduce the number of compounds, this will give us a better chance of having a simpler system to detect cancer. So we used vector analysis and reduced the number of compounds from 13 to 5. And we did another validation study in the 5 compound, and those showed diagnostic accuracy of 85%. And this is a prospective study in different multiple centers in a different time point by different researchers. Also, not only in esophageal and gastric cancer, but we have done this also in colorectal cancer. So this is another study which we compared patient with colorectal cancer with patient with benign disease and patient with a normal colon. And we found that there is a panel of tests which you can differentiate between a panel of compounds which can differentiate between cancer and no cancer. It's not only like this, but if you look at the graph on the right, so this is a control group, and this is patient with colorectal cancer. It goes high, the volatile compound. Post-operative period, it goes down. And then if there is a recurrence, it goes high again. So this gives the concept that volatile organic compound and the breath test could be used not only as a diagnostic, but it could be used for surveillance to see whether people are at risk of a recurrence. So this is an upper GI and colorectal cancer. But what about cancer in general? We did a systematic review on diagnostics and breath test in cancer. And we looked at 87 studies in the period between 2000 and 2017. And actually, this number of publication has significantly increased over the last 3 years too. We looked at the patient-related factor. We looked at the methods of collecting breath. What are the environmental considerations? And also look at the instrument used, whether it is gas chromatography or direct injection mass spectrometry. And this is pooled analysis. Just give us an idea about the test in general. It doesn't give idea about one test. Just give us, if you look at everything together, is it a promising field or not? And the area under the curve is 0.94. This is pretty high, actually. So what does it show to us? That it is a promising field because it could be used in diagnostics. When we did a pooled sensitivity analysis of all studied, it shows that it's about 80%. When we looked at specificity, it's about 90%. As you know, that the sensitivity and specificity dictates whether the test is used as a diagnostic, whether you use it to rule in disease or to rule out disease. Now, it is very important to just reflect about promising results to see, are these ready to go to clinical practice or not yet? I think there are certain steps which are required before we say this test is ready for clinical practice. The first is we need external validation studies. The majority of the studies which I showed you in the systematic review were studies which has been used as first study with an internal validation, which means that the validation sits in the same time of the population which has been the test is created. And for a test to stand in clinical practice, it needs an external validation studies among the population where the test has been intended to be used. The second thing is, we don't know whether there is variation between population, because the microbiome set, the metabolism will change, and we don't know whether this will change the diagnostics of the test. Also, before having a test in a clinical practice, it needs standardization of the breath collection methods and the analysis. Taking the blood is a standard method. So if it is, we need to have the breath test in a standard way, like we take a blood test. So, and the studies we require for the next stage will be large studies. I think the next study we are planning in esophageal cancer will have few thousand patients. So what is the breath test we can envisage to see in a clinical pathway? If the patient has alarming symptoms, then they will have endoscopy straight. If somebody has bleeding, if somebody has severe dysphagia, those people will require endoscopy. There is no doubt about it, because even if it is not cancer, we need to know why. If it is bleeding, we need to stop it. But if the patient has non-specific symptoms, if the patient has indigestion, if the patient has heartburn, which is very common, without not in the age which you worry about especially, then we can do a triage test, which is the breath test. If the test is found positive, then the patient can refer to endoscopy. If the test is negative, then we can treat the patient symptomatically and redo the test again. So in this way, the breath test can act as a triage test, which direct patient who require treatment and require endoscopy in a very simple way. So this can result in a stage shift of the disease. Rather than the patient go to the general practice few times, then they have the endoscopy, they have a test, a straight breath test. If the breath test is positive, they have endoscopy. And if the symptoms continued, then if not endoscopy, then have treated. If symptoms continue, to have endoscopy. The other application will be the breath test for people who have a treatment, neoadjuvant chemotherapy. We're doing now currently studies to predict the response to chemotherapy using the breath test. So the breath test is positive, and if the breath test change, mean that chemotherapy, patient responding to chemotherapy. Also, the breath test has a role which we will be looking at after treatment, after surgical resection, whether it can be used to pick up early disease recurrence. So in your program of minimally invasive surgery in the era of disruption, the disruption can be at the front line. The disruption will be to change the pathway of the patient, to get patient an early disease, and the earlier the disease, the most likely will be treated by minimally invasive surgery. Thank you. You are mute. You are muted.
Thank you very much, George. It was a really amazing update, and I learned a lot. Let me introduce my co-chairman, Professor Arcela. He's head of surgery at the University of Philippine General Hospital. Giorgio, welcome. Thank you for coming.
Thank you, Davide. Congratulations on a very informative lecture. Very interesting, Professor. Professor Hanna, I enjoyed that piece. I I wish there were more participants listening in to your lecture. It's very, very interesting. You know, I hardly read any articles regarding the breath test for upper GI cancers. But indeed, it's been with us already regarding breath test for H. pylori.
Yes.
Chronic presence of H. pylori leading eventually to malignancies like gastric cancers. Is there any correlation, if I may throw out the first question, regarding, you know, monitoring patients with H. pylori, chronic presence in biopsies or breath tests as that, and then developing cancers in the future? Is there any significant connection now between these breath tests that you are developing?
So we know that breath test, you can pick up H. pylori.
Right.
That's well established. And we know the breath test, we know with H. pylori, there is a high instance, not a high association with gastric cancer. The question really, do we follow everybody with H. pylori with a breath test to see whether they develop cancer or not? This is an economic question really, rather than a scientific question, because a lot of people will have H. pylori. The question really, do we do all of them to screen all of them or not? I don't think now economically, maybe, but I think we can do high-risk patient who develop symptoms. Correct. If somebody is a high risk, develops symptoms, then we do the test. I think currently either do it based in symptoms or do it based on age.
On age.
As a risk factor with symptoms too.
Right. Thank you for that. I was seeing your recommendation that high-risk countries like Korea, Japan, and maybe some Latin American countries like Chile, where gastric cancer is quite prevalent, then maybe if they do have these two things, positive on breath test, that will be a good population to study, wouldn't it be, Professor?
I think this is wonderful population to study. And actually, I started as well to collaborate with some colleagues in Hong Kong and other places in Far East to do the breath test for the local population, because if the test stands, it could be a very attractive screening tool, because that's the best thing to do, because it's the screening tool. It is very non-invasive, so it will be very attractive as a screening.
Absolutely. Thank you, Professor.
You're very welcome.
So thank you very much. I think, Jojo, we need to conclude the session because a few more sessions coming up. Thank you, George. Thank you, Professor Hanna. Thank you for always your support and to make you wake up so early in London, 6 o'clock. But we really appreciate, and from all surgical community from Asia and from ELSA, we really thank you from heart.
You're very welcome.
George.
Most welcome.
Thank you so much.
Care.
Thank you.
Thank you, Joe. Thank you, Jojo.
You're very welcome.
Okay. Bye-bye.
Thank you. Bye.
Stay safe.